This is a Byja Broadcast Enterprise show.
In Mexico, if the numbers that we pulled are accurate, they spend about $1,588 per person on health-related costs. PatientZero, $1,588 per person on health-related costs. In the U.S., any idea how much they spend per person on health-related costs?
Is that in a year?
I would say, well, let's not go into time, but let's just throw it in there.
Okay. I would assume Americans spend way more than that. The notes is at least 10 times more, which doesn't surprise me.
Here comes Byja Radio. Byja Radio. With Dr. Byron Jasper and PatientZero.
Welcome to the Byja Radio Show. Recording live.
All right, we are back like we never left, and that means that this must be another amazing season 5 of Byja Radio Show. And season 5 of Byja Radio Show tells me that we're not going anywhere. It may take us a little bit to get back in the saddle because, we're adults and trying to live lives and stuff like that. But ultimately, we are going to come back and give the people what they want. And if I say we, that must mean I have the co-host with the most sitting in the passenger seat, sitting in the co-pilot seat, giving the people the oohs and ahs because they come to the radio show for him and him specifically, the one and only PatientZero. How you doing today, brother?
I'm fantastic, brother. I'm just proud of the fact that we're still on the air. 5 seasons, that's a lot. I feel like we've played more than Zion Williamson at this point. So I'm excited to be here. But I still think the people come here for you. It's a medical podcast. Why was a medical radio show? Excuse my French. Why wouldn't they come to see the doctor? I don't know. But I think it's all about Dr. Jasper.
Agreed. We'll agree to disagree. Again, if you're listening to this at this point, or watching this at this point, since we are on YouTube, we will say that we did have social media posts that tried to clarify who people come to Byja Radio Show for, and the jury is still out. I'm just going to go with that. Why? Because, people maybe didn't want to hurt feelings and tell me that, I'm second place, and that's okay. But the point is if you are listening this far, we appreciate you, and we have an amazing season lined up. The idea of the amazing season is to give people discussions about topics that are relevant, topics that are relatable, and more importantly, topics that are recent. And PatientZero, I think we got a recent one because, believe it or not, I was in a few different rooms and a few different discussions, even in some group chats. And this message came to me about the topic we're talking about today because people oftentimes hear certain things and it gives them the sense of, well, we're missing this and we need this and we don't have that. And, why in this country we don't do things like this person and that person. So it made me say, you know what? We probably need to discuss this to try to get some clarity around the topic. And that topic is universal healthcare in different countries. Now, PatientZero, I'm sure you're an international expert in terms of travel and all things that are potentially outside of the United States of America. Me, on the other hand, I'm probably a little more domestic in the sense that I'm cool where I'm at. All that being said, talking about universal healthcare is tricky because a lot of people hear the words universal healthcare and automatically think everybody has access all the time. And that means that if everybody have access, then we are thinking that everyone has better access and better care and things of that nature. Well, people think universal, it means free healthcare, no bills, you get in, get treated, everything's great. Well, that's not always the case. And what we recently heard from the lovely country beneath us in North America, Mexico, is that they are going to a universal healthcare system. And why don't we talk about it at Byja Radio Show to kind of clarify what this means? PatientZero, I'm going to just ask a quick question before we get into stats. When you hear the term universal healthcare, I've already said a few things, but what comes to mind if that just is said to you, those two words, universal healthcare?
So if I hear universal healthcare, I think of things where everybody has access to healthcare. Now, kind of to your point, if you have access, that doesn't mean that you have the VIP service, you have better healthcare. That just means you have access. So what universal healthcare is not is I can go anytime, everything is covered, and it's not no stress, no bills. You get access, you'll get a bill, everything may or may not be covered, and you may have to wait because just if you have access, everybody else has access. So might be some waiting. But, you know, as compared to what we have here, um, you may be able to get the services that you need or at least basic services where I think people in America are priced out of some services. So that's where that difference comes in.
Gotcha. So I think ultimately you hit on some points that we're going to talk about, but the thought process is you have access. It may not be access in the way that we all tend to think of it, where some people think universal means everything's better, but it is indeed more access, which is something that we oftentimes may not have here in America. So that is spot on. And I think we are going down the right road. But let's go ahead and add a little more meat to the bone. With that, let's talk about statistics and talk about kind of what healthcare looks like in Mexico for people, because a lot of people in America may tend to hear universal healthcare and automatically think that it's better. And if not think that it's better, they may also hear universal healthcare and think it's worse, right? Like, oh, we have the best healthcare ever. So we need to clarify this and give people a little more context to think about the pros and the cons of both approaches, both in America or elsewhere where universal healthcare may be a thing. So, PatientZero, we always talk about the thing that everybody comes possibly to the show for, besides you and me, are the stats and the math. And of course, why do we like math, PatientZero?
Because numbers don't have an opinion.
Right. So based on that, we will give some statistics that we will talk about the Mexican healthcare system and also give some definitions and some context. So PatientZero, why don't you help the people out and share some stats about the Mexican healthcare system as it is? And then again, we'll go through some definitions as well.
So currently, about 78% of Mexicans have access to core services. So you hear a number like 78%, you're like, oh, it's a lot of people. But that still leaves 1 in 5 people without consistent access. And those who may be quote unquote covered still may be waiting weeks or months for healthcare.
Absolutely. So the idea of being covered is not the same as being in care, right? And not being cared for. So I think that's important because what ends up happening is people will hear universal health care. So we have more coverage. So that must mean they get better results. Not really the case. So basically, let's go into a little more detail about what Mexican healthcare looks like currently. So Mexican healthcare, as we know, from a quick dive into what is or what isn't going on in their system, it's broken down into 3 separate bodies that are getting healthcare in the country. The way they do it is they have 3 different groups, and 3 different groups get healthcare in 3 different settings, if you will. And by doing that, they literally are separated, and what they're trying to do is bring them all together. That's the simple explanation. We got 3 different groups getting healthcare in the country, and instead of having 3 different groups, how about we just put them all together? Well, some people would say that's similar to what we do in America, right? We have however many different insurance providers. How about we just put them all together? So it's a similar concept, but let's get a little more specific for them. So they have one called the IMSS. And again, if you speak Spanish, you can definitely look up and translate what that means, but I'm not going to do it because I will butcher it. The idea is IMSS is private job workers like employer-based insurance in the United States. Then there is the ISSST. So the I, 3 S's, and then TE, and that's the potential coverage for government workers in the country of Mexico. Then there's the IMSS Bienestar. And again, I'm possibly butchering that, but that is for the uninsured or lower income population. So you have one group that is technically covered through private job workers, employer-based insurance, if you will. Then you have government workers, and then you have almost everybody else, the uninsured, the low-income population. So basically, it's like having 3 different systems of healthcare coverage. And at this point, those 3 different systems don't really talk to each other. They do things in different buckets. They do things in different ways. There's really no communication between one or the other. There's no overlap. And that's what they're trying to bring together to where it's a lot more universal. And basically, you're having people have that experience of, well, if I'm in this group, I want to move to this group. If I move to the second group, I'm going to get better care. Well, we're trying to eliminate that in terms of what the Mexican population is trying to do from what we know. And that's going to hopefully give people better access. Better access hopefully will give them better care. That's not always mutually the same. It can seem like that, but it's not. But that's the reason why they're moving more into universal health care as opposed to just keeping people in three different buckets. So, Patient Zero, what are your thoughts on that? Does that sound really familiar to you where people are potentially in different buckets getting different types of care? Or is that something that, we've never heard of ever in healthcare anywhere?
It sounds very familiar, especially when you get into terms of, when you're looking at specialists, right? So everybody isn't as fortunate enough to be a part of the Byja clinic and get this fantastic healthcare. So I don't have to worry about finding a primary care doctor, right? But some people, but like any type of plan that you have, you could find a primary care doctor within your quote unquote network, right? But the problem that I foresee with systems like this and what we have in America, you may have a special type of situation where, depending on the type of coverage you have, you may not be able to see the specialist that you need because that specialist only takes these insurances over here and it doesn't take the insurance that you have over here. Or you can just pay them out of pocket, which gets really, really crazy expensive to where only your 1%ers could actually afford that, right? So it seems very, very problematic to me. For example, let's say you need a cardiologist, right? Our good buddy, Stephen Kelly is IMSS. Well, you're ISSSTE. And now you're having to find a different cardiologist who may not be as good as Dr. Kelly. But so now you don't get the care that you need because he's over there. It's just overcomplicated and it just creates more red tape to care, in my opinion.
Yeah, absolutely. And I think you're spot on when you said they may have doctors who are in one category and one category only. They're not universal, if you will, right? With the idea of universal healthcare. So that doctor is only caring for the uninsured or low income population. They may not cross over into the government side. So you would say that's a little strange if you're in America because, hey, the doctor doesn't necessarily only stick to one population. Well, some do, right? But a lot of us don't. We will basically see people in different insurance plans. So it doesn't really seem like we only stick to one population. But in their system, they kind of do from what we know. So that is why, again, that's a huge, huge problem for them that they're trying to fix. One of the other things that they have, again, is that they have coverage versus access. Coverage versus access. So you may be covered under one of these three buckets, but that doesn't mean you have access. So even though you are potentially in the IMSS star, you're still potentially having to pay out of pocket because, again, you're in the low income, uninsured bucket. You still may have to come out of pocket to pay to fill that gap, right? So approximately 40% of their total healthcare spending may come from their out-of-pocket expenses, and that's not a good thing. So even in a universal system, people are still having to pull out their wallets. They're still having to pay dollars and cents, or pesos in this case, to potentially end up getting care because, hey, it's universal, but it doesn't mean that you have coverage. Again, you have access, but you now have to pay for that access, right? It's akin to the idea that, hey, you technically take my insurance, but when I give it to you, it doesn't cover 100%. So even though I am in the door, I'm still responsible for 60% out of pocket. So people will hear universal and think everything's covered. No, 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 no. It just means you have access to get into the door. And that's another problem that they have. And they're potentially trying to fix, but also they're trying to figure out how to make this make sense because now we're having more people with access. That means we got to spend more money. More money being spent means now we have to find a way to fill in that gap. Gap being filled in doesn't just happen. It doesn't just magically have dollars fall out of the sky. And the money not coming means that someone has to fill in the gap. And usually it's the patients, right? So that's a huge problem. So with that being said, Patient Zero, are there any examples you like to give people of what that could be like when you say, hey, you have access, but you don't have coverage? So I gave one, but any others that you want to give people that may kind of relate to where we do here in the States, or anything else that you may say, well, this is another idea of how we can frame this?
Well, it sounds like some of these insurance plans that people just get because they can't afford any type of any better, right? If you're not employed, what a lot of people do is they'll have something like a critical care plan, right? So you have insurance, but it's pretty much if you need to go to the hospital. So if you need to go to a specialist, you have nothing. If you need to go to a primary care physician, you have nothing. So you can go and see a physician, but it's going to cost you a lot of money, and the prescriptions will cost you a lot of money as well.
Mm-hmm.
So that's what that sounds like to me.
Yeah. So, and I think the idea is that you're going to still have access to medications, but that doesn't mean that they're going to be covered. So you still got to pay for them. You still have to come out of pocket. You may have universal coverage where you now have access to the specialist, but it's still going to be a lot of people and there's still going to be a lot of waits to get to the specialist. So it's not like, well, it's universal. So now you get to basically jump to the front of the line. You still need to have doctors to be able to see all these people. You still have to have hospitals to be able to take care of all these people who now have access to the system. So you have to figure out how to fill those gaps. It doesn't just mean that we turn on and hit a button and everybody now has access. So now everybody gets healthier. Doesn't work that way. I wish it did because that would make my life easier. But more access doesn't mean that people are going to be healthier. Care is going to be less expensive. Wait times are going to be shorter. It really is possibly the opposite. And I think the
Do
idea
you
of
remember when?
capacity is a thing. Go ahead.
Do you remember when Earl K. Long was open?
Absolutely. Yeah, I was definitely a
I felt like,
resident while the Earl was open.
wow. So did you work there?
I did not. I was still in the beginning of my residency whenever it was open. Usually the people who went to Earl K. Long, which is basically like the charity system here in Louisiana for Baton Rouge at least, you would have to be a senior resident. So I was still a junior resident and an intern. So I didn't make it there, but I knew about it.
You knew that you go to Earl K. Long and everybody had access to Earl K. Long. But man, you pull up to Earl K. Long, man, you might as well bring you a snack, pack you a meal or something, because you will be there forever. And unless you had something that was life threatening at that moment, you were going to wait. Whereas if you had insurance and you might have wanted to go to, I don't know, Aleda Lake or Baton Rouge General, where it wasn't a charity type of system, but they were looking for you to have some type of coverage, or you would be expecting to get a bill, you wouldn't have to wait nearly as long to get care, and you'd be in pain, or you'd suffer a lot less.
Yeah. And I think you're spot on with that as an example. And other hospital systems across the country probably have a similar thought that you go to the place where it's free care, so to speak, and the quality maybe not be as good. The wait times are longer. You have less staffing. You have less supplies, but it's free, quote unquote. And then you go to the place where there's money being spent and more money going into the facility and more people who are on staff. It's a lot faster. It's a lot cleaner. It's a lot more efficient. Well, that's kind of what this is possibly going to be. And that's why people who automatically say, well, yeah, we want to do what they're doing in this country. You got to do it with a little bit more scrutiny than just one size fits all. And one more quick thing that I think will highlight this, which we talked about briefly, was capacity. Is the idea is that, again, you need more doctors, more beds, more hospitals to be able to care for all of these people who are now getting access when you just throw everybody into one big pot and just say everybody can now see every doctor and go to every hospital and get care in any and every way. Well, in Mexico, if the numbers that we pulled are accurate, they spend about $1,588 per person on health-related costs. PatientZero, $1,588 per person on health-related costs. In the U.S., any idea how much they spend per person on health-related costs?
Is that in a year?
I would say, well, let's not go into time, but let's just throw it in there.
Okay. I would assume Americans spend way more than that. The notes is at least 10 times more, which doesn't surprise me, because I'm pretty sure they take more than $1,500. Matter of fact, I know for a fact they take more than $1,500 out of my check per year just for my premiums, and that's before I filled the prescription. That's before I got any type of blood work, saw a specialist, had any type of procedure or anything like that. So yeah, we spend way more than that. And honestly, that $15,000 per person, I think that's rather conservative. I think Americans spend a lot more money than that, let's say in the calendar year, on healthcare.
Correct. And I think that's the idea. We will assume it might be a year, but maybe it could be 6 months. Who knows? But the idea is we spend way more in America on
Yeah, it's not
healthcare.
close.
And some of it could be waste, right? Some of it could be just stuff we are spending money on we shouldn't spend money on, and things being marked up way more than they should. But if you're spending 10 times more on something, more than likely you're hoping, or at least wishing, the product will be better, right? So that could be two sides to that story, that they spend way less and they still have decent health care versus we spend 10 times more and we basically run circles around their health care. But that's the idea. You can't just imagine that you're going to have more people spend less money and everybody's going to win. It doesn't really work that way. And you can't imagine that all these people are now getting access, that you're just going to have the same workforce and it's going to be fine. If you don't put more funds into hiring more people to care for more of the new patients coming into the system, you're going to end up just having the same issues with just one big person, one big pot, one big group, one big insurer, if you will. So that's a huge problem. And that's something that I think they're going to run into, where it's not just, hey, everybody has universal healthcare, we're all happy. No, it's, well, we have universal healthcare, but now we got a lot more work to do to get it to where that universal system works way better. And this is across the board. In different countries that have universal healthcare, they oftentimes run into these same problems where the wait times are excessive. You're waiting 3 or 4 months to see a doctor because they're all now overrun with all of the people coming to them because everybody now has access. And that could be a specialist, that could be a primary doctor, it could be somebody who's just getting physical therapy. We don't want it to be where it's again, one size fits all means everything's perfect. Now, it doesn't mean it's all bad, but we definitely have to think about this a little bit more than just saying, hey, let's go do that because they do it over there and they do it over there. It must be great because I've heard the great things. Well, you also got to pull the curtain back and look at the not so great things. Okay. So PatientZero, we're, I think, doing good on time. Any other thoughts you wanted to share with the people for the Byja Radio Show, Season 5, Episode 45, about this topic in universal healthcare so far? Because I think we did a good job of talking about Mexico and how they're potentially doing things and where some of the gaps may be. We didn't really go into America yet. We'll come back to that. But anything you want to do to close out this segment to just frame some of the things that people may want to think about when it comes to this topic?
So, I think the problem with American healthcare, even before we get there, isn't the technology or the ability of some of these American doctors, because I think the advances in medicine and the ability of these doctors are amazing. And I think, you go to some of these other countries like a Mexico, and you may not have that same type of ability or the same type of technology as readily available. We always talk about the fact that the healthcare system is broken, and which it is, but that's not a knock at the ability of some doctors or the technology of medicine in America, which I think that is amazing. The issue is the complexity of the billing systems, the insurance, and a lot of times what you have to deal with as a patient, because the the onus is on you to get healthy and to deal with where you should go and do your own research and find your own doctors, especially when you're talking about specialists and things of that nature. So I just want to kind of clear that up to where, we look at all these other models and, we hear things like universal health care, which I'm not going to knock it because I think everybody should have access to health care. But we got to be careful when we talk about other countries' models, because a lot of times the technology, the ability, and the things doctors are capable may and probably be better here. Even though the parts that are broken, but I feel like it's a very fine line when we're discussing how broken the system is, and we need to be specific and just discuss that it's the complexity of the billing, the involvement of insurance and things like that, not the technology and the capability of the doctors.
Yes, sir. And I think ultimately one of the other things that may make it a little bit better for universal healthcare, that is probably easiest to see and the fruit being a little bit lower in terms of access, is medical records. I think that's the biggest thing that I would close out on. With a universal system, it may be a lot easier for basically hospitals and doctors and clinics to talk to each other, because right now you're not worried about, well, this claim was filed on this plan and this person didn't change the insurances and this claim was filed on this plan. So now we don't know what they did or didn't do, what was or what wasn't diagnosed, what was or wasn't covered, what medication they did or didn't get. All of that disjointed feeling is going away potentially by bringing everything together. So that's a benefit I think that could be helpful. But I do agree with you in that if we now have the comparison of, well, America has a broken system and the way to fix it is to just throw more people into the system and don't change anything else, I think it's just going to be basically throwing more people into a bad system. So we have to get better at not only giving access, but making sure once access is given that the rest of the system has already adopted better metrics, better approaches, better protocols to where those new people enter into the system, they have better outcomes and not just more people entering a bad system. So with that, we will close out segment 1 and we will come back for segment 2, of course, of Byja Radio Show, episode 45 of season 5, right after this. Hello there, it's Dr. Jasper from the Byja Radio Show. Are you tired of the broken healthcare system? Frustrated by long wait times to see your physician, rush visits, and the sky-high healthcare costs that come with those rush visits? Yeah, I hear about it all the time. So if you're tired of dealing with any of those things, then I highly suggest you check out the book Byja Blueprint, an introductory guide to direct primary care for patients, physicians, and businesses. Written by yours truly, it breaks down all you need to know about direct primary care, a model that makes healthcare simple, affordable, and personal again. The book covers topics like how DPC differs from traditional insurance-based healthcare, what's the difference between direct primary care and concierge medicine, how employers can use DPC to cut healthcare costs, how this model reduces burnout for physicians and improves work-life balance, and so much more. Whether you're a patient, a doctor like myself who was fed up and burnt out, or a business owner tired of rising healthcare costs, this book lays it all out in plain English. So if you're ready for something better, check out Byja Blueprint, available in paperback, audio, and ebook format. Visit bookstoread.com/Byja Blueprint DPC and get your copy today. All right, and we are coming back in for the second segment of episode 45, season 5 of Byja Radio Show, where we are talking about universal health care and the system of universal health care that the country of Mexico is looking at starting, if you will, and then where we are in America and how there may be some good things or some not so good things, and things that we may want to pull over into the States versus things that we want to kind of keep. So we're going to hopefully do this in a way where it makes more sense. I believe we did a good job of this in segment 1, but let's go a little bit deeper. So PatientZero, we got some notes in front of you and myself, and I want to see if we can start to kind of highlight where there are things that are very similar in the Mexican system that they currently have and or things that we currently have. And then the opposite, where is there a gap or things that we have that they don't have that may be good, or things that we have that they don't have that may not be good. So let's go through them and try to be a little bit more granular for people listening to hopefully clear some things up.
Sure. So, I mean, if you really look at it, the first thing that stood out when we were talking about the Mexican system was the 3 different categories, where you had the government, the private job category, and then you had the income restricted category, right? And where most of our healthcare is based off of insurance, and it's based off of insurance through your employers. So the job insurance, that job employer insurance piece of it is a big similar piece. Then when you're talking about the Medicaid, the income restriction, that's very similar to our Medicaid part of it, right? Now was slightly different. We don't have a government job based system, because your government job based system, your government jobs use private insurance just like your private employers do. But if we did, it'd probably be similar to Medicare, which we use in terms of age. is very similar. Their current system in place is very similar to the system that we have in place. The main differences, in my opinion, is that government employees and private employees have very similar care here, where in Mexico it's different. But the three different
Absolutely.
categories seems very familiar to what we do here.
Absolutely. And I think the idea, like you said, private insurance versus their private plan that is employer based. Most of our private insurance is employer based. I think the low income bucket that they have is very similar to the Medicaid system that we have. They have a government insurance, if you will. And I do think the government insurance we have may be similar in Medicare, but it's not quite where you get, for lack of a better term, government insurance where it is, in my opinion, related to a job. So that may be their version of Medicare, which is slightly different, but could be the same. So yeah, those three buckets are very similar in a way. They don't necessarily overlap in Mexico, whereas ours may, where your doctors can see patients who have Medicaid and Medicare, as opposed to the other way where those are kind of siloed. So I think that's a huge thing. I think some of the other things that we should talk about are, again, some of the strengths that we have that they do not have, or and vice versa. So one of the strengths I think that we've talked about is basically having the funds and the resources to pour into our system to make it better. A lot of countries don't have that ability to take a lot of that capital and pour it into technology, pour it into specialists, pour it into cutting edge hospitals and different techniques that allow us to have better outcomes. Whereas some of the other countries are spending a lot less and trying to do the same thing. And that's why a lot of people will like to come to the States to get care from where they are, because they know that we have a lot more of that cutting edge technology, oftentimes because we're spending a lot more on it. So I think that's a huge thing, that there's a contrast. And I think the last thing is just basically, as we talked about, the numbers, right? The numbers of people who are potentially out of the system versus the people who are in the system. So I do think they have a lot of people who are possibly not in their systems, even though it's three buckets and the three buckets are there. You still have to probably have some skin in the game or spend some money to get access. Whereas they have people who don't access the system at all. We're very similar in that way. We may have, millions and millions and millions, or if not tens of millions, that are uninsured and just don't get care whatsoever. And of course, if they end up getting care, it's when they have something bad happen. I think that's very similar in their country, where they have people who don't get care. And then when something bad happens, that's when they start to enter the system. And they're trying to alleviate that by saying, hey, let's make sure we give more people access so we don't have to wait until something bad happens and they'll show up and have a problem. And then we got to make it better. How about we do something on the front end and give them access earlier, and then they have more access, they're more likely to have better outcomes. So I think those are the comparisons that are easy to see and comparisons that are very easy to grasp. PatientZero, anything else that you would say, a comparison wise, that you would say, okay, yeah, I do want to also touch on this. This is something that came to mind.
Now, I think you hit it on the head.
Yeah.
You know,
Well,
from what we know, they're very similar.
Well, I think there's a couple similarities as well, but I think the contrast is something we can easily see. So usually in America, we have way more capacity, right? Now, I think the comparison here, whereas there is a contrast that we have more, it's just a question of, does that mean more is better? Well, some people say absolutely it's better. Well, let's talk it from the clinician side. Well, you have more capacity to see people because you may have more resources. But if you're seeing 50 people a day, PatientZero, does that mean that it's a better system? Whereas these other people are only seeing 13 people a day. You're like, well, they don't have as much capacity. Well, maybe they do. They just don't want to kill and burn themselves out and kill the capacity because the person decides, look, I'm leaving medicine because it's just too much. Tell me your thoughts on that, if that makes sense.
I mean, if I were a clinician, I would rather see 13 people in a day than 50. Like, I don't know how you see 50 of anything in a day and be effective. Like, I just don't know how things how things don't start running together. Then you got a chart in between that. I think that's where errors happen. And then the problem is, this is health. This isn't like your order at the restaurant where you bring somebody the wrong order and, you just send it back or whatever. Somebody's unhappy. You make a health and you make a mistake in healthcare or somebody could die. So, it's a big deal. And I don't want to make that seem light on any stretch. So yeah, if you're only seeing 13 people a day, I'd much rather that type of system than a system that makes you see 50 people a day in an 8-hour span. Like that's too much for the best and the brightest to even handle because everybody has to kind of seem alike, look alike, everybody you talk to, that has to run together at some point. And if you don't have, even if you have the best organization skills, you're probably going to make an error. So to answer your question, I would much rather a system where a physician's only seeing 13 people versus 50 people in a day.
Yeah.
It's not even close.
And that's why I said I think that's some of the stuff that we may look and say, well, they have more capacity in America because you can see 50 people a day, and you have the rooms that you can see 4 people roomed all at the same time at 3:00, and we can run through all 4 of them in 15-minute visits, so that's enough to fill an hour, and that's a good use of time. I mean, for who? Because I think, as you just mentioned, that could be a very bad use of time if you're missing something in one of those 4, and 25% of your population now has a bad outcome because you're rushing through 15-minute visits. So the capacity part may seem better to say we have more capacity here, but it's, in my opinion, how do you use that capacity? You don't want to say, well, we have full capacity at 100%, and we're basically using 100% of all the resources, because if something goes wrong, those resources are now exhausted, and now we're basically going backwards because we went from 100%, now we're down to 50 because one of the doctors burned out and decided that I can't do this anymore. So I think we have to be careful not to just think they're having less in certain areas and we want to mimic we don't want to mimic them. We want to go the polar opposites. Because again, you may say, well, we have 3 beds, whereas they have 1 bed within a hospital. But if those 3 beds are often filled with people who could have been treated outside of the hospital, and if we had more access to people outside the hospital, they wouldn't need those beds, then I think it's a better use to say capacity isn't always the best thing. And sometimes people don't think about it like that. They don't think about, do we have capacity and we're overutilizing that capacity? Do we have capacity and we're over relying on that capacity? Or are we using it wisely, where instead of having 3 beds that are full all the time, how about we drop to 2 and then put more resources into the outpatient side to where now we have less need for 3 beds and they're full all the time. Rather, we have 1 bed and an extra one, and more people are staying out of the hospital. So that's what I mean by the capacity side. Now, we do want to highlight the idea of where America, I think, does well. We do a good job of doing a lot more screening and having a lot more resources to screen for things like cancers and other preventable diseases, and doing things very well. Up until recently, we also did a really good job of doing vaccines and keeping people vaccinated, so we didn't have high rates of communicable diseases that would potentially run rampant. But of course, we seem to be going backwards. So that may be something that the universal health care could be a lot better at, giving people access to where they now have access to those resources, and they're not having to rely upon all these different insurance plans to cover vaccines and have vaccine recommendations and have different medication recommendations and medication coverages. It's now kind of lumped together where people have access to the meds that they need most. And it's a little bit more reliable than, well, if I'm on this plan, I get coverage. If I'm on this plan, it's not covered. So now I don't get my medicine, and now I got to switch insurances and do all this running around. So I think that's something that may be better, and it's something that we could consider, but also something that is going to take a little bit of work to get to that point. So I think we're doing a good job there. Let's do this, PatientZero. Is there anything you would say we as a country could learn from the concept of trying to get more things in a universal healthcare space? If not doing it across the board, is there anything you would say, this is something we can learn? We can do this takeaway and potentially come out and say, hey, we looked at these countries, they're doing this, and we see this works really well within this setup. And even if we're not going to do a universal healthcare across the board, if we do more of this, we probably will do better, especially considering we do this well in this area, but we can do better in this area, if anything at all.
So I think there's 2 things that I would like to see done better, assuming that we won't ever lighten the workload of healthcare professionals. It just seems like we're destined for everybody to see 50 patients in a day, right?
Yeah.
But I think outside of that, two things that'll help. Number one, you can make all the records and all the systems talk to each other. Or you in my chart, or you in this over here. Do those systems talk? Are all your vaccines up to date in every system? They should just be one healthcare system. And I know that everything in America is privatized. There's competition. That's what the economy is built on, right? So I get that. And there's going to be all kind of software companies vying for position in terms of building out medical software. But there should be one record software in America. That way, every doctor can see every record for each patient that they tend to, right? Or that they care for. That's number one. But number two, I'm not sure what's the approval process for someone to provide healthcare insurance. But once somebody is a healthcare insurance provider, they should be able to work, and they should be made to work with all doctors. Every doctor should accept every insurance. That way, no matter what kind of coverage you have, no matter what your employer provides you or whatever you could afford, even if you don't have the same cost as everybody else, you should have the same access to the same doctors as everybody else. Because it's very, very possible I can have this group of providers, because I'm Dr. Jasper, I'm getting up there. I'm 41 years old. So I need more care than just a primary care physician, right? I have a dentist, I have an eye doctor, I have a cardiologist, I have an endo doctor, I have an orthopedic specialist now, I just had a procedure done at the neurological center. So I have these group of specialists, right? Let's say I lose my job tomorrow and find another one. I may have to find a whole new group of doctors because I may not be covered by what I have. And I feel like those two things will allow people to have better care, or at least more consistent care, because where you work and who you work for is a big hurdle or gateway to care.
Yeah. I will agree on everything you said and add on a little bit more. I think another takeaway that may just seem like a broken record for us, especially if you've been listening for 5 seasons, is that we do need more access for people to where more doctors take more insurances potentially, so people aren't having to potentially fragment their care when insurance changes or jobs change. I do think that part makes perfect sense. I think the other part that makes perfect sense that I think anybody can get behind, especially considering the Mexican approach to giving more people access, is strengthening primary care, right? That's the broken record part that I alluded to earlier. If you have more primary care, you probably won't have as much of a strain on the system where cost is going completely through the roof. You are preventing disease. You're preventing people from having to go to the hospital. You're preventing people from having kidney failure and heart attacks, to where we now have we have better outcomes. We have more people seeing the doctors early, and the access is not just something that we gave to people, but they're not going to use it because, hey, you got access, but you can't afford anything. And now you can't afford anything, you're not going to get any care. So now when you finally do get care, it's going to be in the hospital. And of course, we're overrun because we didn't do all of the infrastructure and things of that nature. So strengthening primary care, I think, is something that the U.S. can really and truthfully learn from these types of systems, that they're not just giving people access and saying, well, we're going to keep primary care all the same. We're not going to reimburse any more than we should. We're not going to give people higher wages on the primary care side. We're not going to have a incentive to go into primary care. We're going to just say, hey, let's keep everything specialty focused, give more people access, and think that that's going to work. Well, the specialists are going to get to the point where they burn out a lot faster because everybody's going to just go straight to the specialist thinking that, well, I got back pain. That must mean I need to see a specialist. Well, I got chest pain. That must mean I need to see a specialist. And of course, I've got to tell a story when I think about this, because I was literally a resident And when, I'm sorry, let me go back. I was a medical student, and this is when I was really early in medical school, and I was still learning the lingo. I had a patient literally come to us in an outpatient setting and literally say, "Oh man, I just feel so bad. I need a stress test." So, of course, I'm a medical student, and I'm like, okay, no problem. Let me go talk to the attending physician and see what they want to do. And of course, I told the doctor, I said, Doc, the patient says she'd like a stress test. And he said, well, why does she want a stress test? And I said, well, she just said that she's just under a lot of stress and she just needs a stress test. And he said, we can tell they don't know what they're talking about because a stress test is what you do when a person has heart disease. It's called a stress test because we put them on a treadmill and we stress their heart. They are having anxiety and their stress test is they think they need to talk to somebody. But if you don't have that fail safe, that gatekeeping, if you will, they would have went to a specialist, a cardiologist, ordering a stress test when they really need to see a primary care doctor or a psychiatrist. So that's why I said you have to have these metrics and these rails in place so people don't just say, well, I have access, I can do what I want. And I'm just going to go ahead and do any and everything, and it's going to work out. It's not. You're going to have more spending, more tests, more labs, more procedures, and still bad outcomes. And all of that just turns into, well, we should have thought about this differently. So I think the last thing that we can talk about PatientZero is your thought on if we would go down the universal healthcare road, when do you foresee that being something that could be a more accepted discussion? Because I think right now, if you walked into a place and said, should we have universal health care in America, you're going to probably get a split down the middle. That's just my thought. Do you think there's ever a point that if we do more of A, B, and C, we'll lean towards, hey, yeah, giving more access in a universal way, more records being shared among one group, or having one electronic medical record to access? Do you think that would ever happen, or you think, no, we're just never going to get there?
I don't think we're ever going to get there. And the reason is one thing in America, everything is too political because, you got two political parties where one party seems to want to take care of everybody for everything. And the other party seems to only be interested in rich people and seems to be interested in, just allowing people to pay for whatever they can afford. So the term universal health care is always going to spark at least a vicious debate among everybody. And I don't think that that does well because nobody seems to be working with each other to achieve that one goal. Now, if we change the language and see maybe if we can put everybody on one system, even though it's going to be a problem because, you know, you talk about competition among software companies and who gets that contract and blah, 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 and all that good stuff, that those things seem to come about, which would be a challenge. But I think more people, or at least be open to the conversation of giving everybody access to every platform and maybe forcing everybody to upload to every platform. That way everybody has everything versus just having one platform, I guess. But I think we're closer to that than having what we would call the universal healthcare system because everything's political. So I don't see that coming in the foreseeable future, unfortunately, even though that's something that we need to have. Also, something that you said earlier when you're talking about the guardrails and making sure people don't have access or people, maybe having to go through primary care before you get to a specialist. The problem is you have to look at the point of the healthcare industry, which I'm gonna get on my soapbox for a little while, but the point of the healthcare industry in America isn't to make people healthy. It isn't to keep Americans healthy and keep them alive and let them live as long as they can. The main purpose of the healthcare industry is to make profit, is to make money. That's the main purpose. So, to fix a lot of the health issues in America, yes, you do need to invest more in primary care. But the problem is the system won't be as profitable if you invest more in primary care because you're going to see a lot more chronic issues be stopped before they become chronic. And then the need for specialists goes down and then you get things accomplished in one visit versus having to go to 4 or 5. which would be a lot better for the health of everybody, a lot better for the patient, but it's not good for the industry. All this good stuff, man, call me a pessimist if you want to. It just is what it is. If it don't make dollars, it don't make sense. So as long as the healthcare industry is for profit and it's not about making people healthy, all these good changes and all these great ideas that we have won't get implemented because it's going to lower the bottom line.
Absolutely. And I'll add in this one little tidbit, and I think this will kind of drive the point home. As you just said, I don't think it's going to happen anytime soon. I think the way that if it did happen or got close to happening, it would have to be in pieces. As you said, moving towards a more universal electronic medical record for record sharing, moving a lot more towards a universal system where people are able to see the actual images from their imaging record a lot better. And then if this is ever achieved, if not achieved closer to achieving fully, that would probably make it work, would be universal primary care, where everyone potentially has access to primary care. Specialists are obviously specialized, so we would have to be a little bit more strategic at how people get access to specialists. But if we have more primary care physicians that are basically able to give people access and introduce them into the system in a guided, strategic way, it would potentially then lean more towards, look, we gave more access to primary care. This actually works. How about we find a way to open this up where we do this for dentists, where we do this for eye doctors, where we do this for mental health specialists? That part comes in and all of a sudden people feel a little bit better. We have better results, better outcomes. It may lean towards, we now share records universally. We are now sharing primary care universally. Maybe we should do more about this and find a way to do this for hospitals and surgeries and things of that nature. But unless any of that happens in pieces, I don't think it's going to happen at all. All right. So PatientZero, I think we're ready to close out. So what are your thoughts? If anything you want to leave the people with, we're back for, again, season 5, brother. I mean, I don't think the people understand that, we're here. We're not going anywhere. And episode 45, right? I think I've said this at the end of season 4. We should obviously recognize that the fact that there's some people who have recorded one episode in 4 years. We're at 45 and we've only done this for maybe a year and a half. Like, we're working over here. So people, I want you all to, give PatientZero an opportunity to bend your ear a little bit on things that he wants you to take away from this episode, or just in the fact that you're a avid listener of Byja Radio Show. So PatientZero, what you got?
I just sat on my soapbox and talked about, I don't think that we'll have universal health care and for any time soon, and how difficult it would be to get on one accord and all this good stuff. But what you can do as a patient, as what I do my best to give myself a universal type of experience. And what I mean by that is I do as much research as I can in terms of the specialists I utilize, and I keep my own records. So you make sure you keep notes. You know when you saw the physicians last, whether that's your primary care physician or a specialist. You report back to your primary care physician and you create your own type of experience, because you yourself, as you heard many, 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 many times from me, are in charge of your health. So you have to do the best you can in this broken system to give yourself the best health experience that you possibly can, so you can stay alive the longer you can. Part of that probably starts by seeing my good friend slash doctor slash business partner slash frat brother slash a lot of stuff, Dr. Jasper, in terms of seeing him for a consultation for the Byja Clinic. Is free if you say I sent you, right? So go talk to him and see what he can do in terms of bringing you in the clinic or seeing if it's a good fit for you. But give yourself the best experience that you can. Be in charge. Take the ownership of your own healthcare. Do your research. Invest in things like healthcare, health savings accounts, or flexible spending accounts, depending on what your job offers and things like that. And just do your own research and handle your own health care. So take ownership of that. I know that's nothing new that you've heard me say if you've been listening all this time, but it just seemed appropriate on this particular topic. So give yourself the best universal healthcare experience that you can for yourself by keeping your costs down as best you can, doing your research, crunching your numbers, looking at the insurance options that you got. Maybe you pick a higher deductible plan. Maybe you pick a lower deductible plan. But go see Dr. Jasper, talk to him about the clinic, and keep your own records and know exactly when you saw who for what. And that'll give you a better experience because your doctors will make less mistakes.
Absolutely. I will close out with the idea more for the episode than just in general, but I think the idea of universal healthcare sounds good on its face. But if you don't scrutinize, you're going to fall into a trap of, well, they thought it was going to be good for everybody to do one thing exclusively. And now we're seeing that this was probably not the best idea. So instead of running down that proverbial runway and only to realize you're not going to take off, how about we do it strategically? So the question that I think comes up is, would you rather have guaranteed access without any delays or have fast access with higher cost? You might say, yeah, look, I want the access with no delays. But the issue is the cost being so affordable that your quality is going to be really bad. Now, most of the time you can't have both. You can't have guaranteed access with no delays. If you have guaranteed access, the delays are going to mount up and your quality may still not be that good. So now you're in even worse of a situation. So people want fast access, then you may have to pay for it. You want guaranteed access, well, you definitely may have to pay for it, but it's going to be a lot cheaper if you can get access and then wait 6 months, because that's how long it's going to take you to see somebody. So you have to think about it in that way. And if you think about it from both sides, I think you start to have better decision making, better results. And of course, in my opinion, the better results means better care for people who need it most. So with that, we'll close out.
You just made
PatientZero,
me
looks
think
like
of
you got one
something.
more thing.
You just made me think of something. And the old, I know it's an old saying, but it holds true for everything. And healthcare is no different, right? Fast, cheap, and good. No matter what it is, you only go get 2 out of 3. If you want it fast and cheap, it won't be good. If you want it good and cheap, it won't be fast. You want it cheap and good, it won't, like I said, it won't be fast. You know what I mean? Like you'll only get 2 out of the 3. And that's with anything in life. Healthcare is no different.
Absolutely. Well, all right, brother. Well, I think we did a good job of bringing people back in for season 5. We got more in store. PatientZero, where can the people find you so they will know where to come back besides Byja Radio Show to get in touch with you and to have access to you and all the great things that you're doing?
Yeah. So Becknell Media on Instagram is there. George_Becknell on X, formerly known as Twitter, and George P. Becknell II on LinkedIn is my main platform.
All right. And for myself and for us at the Byja side of things, we have, of course, the Byja Radio Show that you are listening to, whether it's on any of your podcast platforms or also on YouTube, which we are obviously flurrying into YouTube and doing more on YouTube. So if you're not on YouTube at this point, please go ahead and check us out. Like, subscribe, share to all of those platforms so we can hopefully grow this and continue to bring good content to the people who are listening. Social media, we're also on Instagram at Byja Clinic and Facebook at Byja Clinic. We're also on LinkedIn as well as Byja Clinic. And myself, overall, you can find me at the clinic or at our nonprofit arm of the Byja Clinic, which is the Byja Charitable Alliance, where we offer the opportunity to donate to the nonprofit foundation with a tax-deductible donation that will allow us to give care to the underserved who may not be able to afford a direct primary care membership. To do that, you can visit the website, www.byjaca.org for Byja Charitable Alliance, or for the clinic for the primary care side of things, direct primary care specifically, you can visit www.byja.org. With that, we will close out Season 5, Episode 45. Thank you all for listening. Thank you all for tuning in, and we will see you at the next episode.